Hello, everyone. Welcome to today's event hosted by the India Center at UCF, and welcome to the panelists for our event on pandemic situations and responses in India and the US, which will be moderated by Dr. Raj Gurupur, an associate professor at UCF. I am Dr. Kirsten Hamann. I'm the interim director of the India Center at the University of Central Florida and a Pegasus professor in the School of Politics, Security, and International Affairs. The India Center at UCF broadens the understanding and awareness of contemporary India and promotes the study of India in the world today and the relationship between the United States and India through partnerships, scholarship and research, education, and outreach. It goes without saying that today's event is timely and highly pertinent as different national responses to and experiences with the coronavirus pandemic are being assessed and evaluated. By comparing these experiences, we can learn from each other. Welcome again. Thank you for joining us for this event. And it is now my pleasure to welcome Laila Chakro, the Director of Public Affairs of the India Center, who will introduce our guests. I look forward to a spirited discussion and I hope you will enjoy the event. Thank you. Laila?
Thank you. Hello, everyone. It's a pleasure for me to introduce our speakers today. Before I introduce them, I would like to thank the University of Texas South Asia Institute for co-sponsoring today's event with us. Today's event is going to be recorded for future viewing on our website. Dr. Varadraj Gurupur is going to be moderating today's discussion. Dr. Gurupur is an associate professor and academic program coordinator in UCF School of Global Health Management and Informatics. He has 2 patents in health information management. Dr. Gurupur won the American Health Information Management Association Triumph Award for Innovation in 2021. And Dr. Richard Selvaggi is a family physician with a specialty in geriatrics. He practices family, geriatric, and emergency medicine. He graduated from the University of Texas, Galveston with his medical doctorate. He is the medical director of Briarcliff Health and medical director of Oak Manor Nursing and Rehabilitation Center. Dr. Selvaggi is an assistant clinical professor of medicine at University of Texas Medical Branch, Galveston. Felicia Sims is a registered nurse. She works as a rehabilitation nurse manager at Briarcliff Health Care Center, a skilled nursing facility located in Greenville, Texas. She previously worked as a director of nursing at a local nursing facility. Dr. Anuradha Pichumani completed her medical degree from Thanjavur Medical College in Tamil Nadu, and she has an MBA in hospital management. She is a gynecologist and fertility specialist. She works as the executive director of Sree Renga Hospital in Tamil Nadu, and she is a board member of the Asian Society for Quality in Healthcare. And finally, Dr. Amitha Marla completed her medical degree and master's in health administration at the St. Agnes College in Mangalore. She is the director of the AJ Hospital and Research Center in Karnataka. She is also professor at the AJ Institute of Hospital Management and an assessor with the National Accreditation Board for Hospitals and Healthcare Providers. After 2 years of the COVID-19 pandemic, today we will discuss the ways these healthcare professionals on our panel in India and the US responded to the pandemic. As the panelists share their professional experiences with COVID-19, we will discuss how this experience may change future healthcare delivery, personal practices, and information systems. There will be opportunity for audience questions following the initial discussion, so please utilize the Q&A function on the bottom of the screen. Now I will hand it over to Professor Gurupur to start our discussion.
Thank you, Laila. Thank you, Kristen, everybody, for having me here and spending your time here. Given the limited amount of time we have, let me jump right into the first question. And this question is for Dr. Marla, and we expect a response from Dr. Selvaggi. So the first question is, what changes have there been to the healthcare delivery process because of the pandemic? Has that had any effect on the cost of healthcare delivery? So Dr. Marla, we want to hear from you first and then a response from Dr. Selvaggi.
So very good morning to all of you all in US and greetings from India. So at the first, I would like to thank the organizers of UCF India Center and Texas South Asia Institute for providing me this opportunity today to participate in this seminar. So as far as the question goes, what changes have been in to the healthcare delivery process because of the pandemic? First of all, I would like to briefly tell about the Indian health delivery system in India. So in India, we have both public health system and private health system. So private health system constitutes up to 60% of the healthcare delivery in India. Whereas public health system in India is constitutes for less than 60%, but then the delivery process is not well developed in India because of the huge population and less expenditure of the government, and it spends about 1.28% of the GDP only, which is much less when compared to other countries of the world. So with this low spending, it is very difficult in the country to provide healthcare delivery adequately, and especially during pandemic. So with a huge population of 1.3 and doctors ratio less than 1 for 1,000 population and lack of isolation bed, you can imagine the difficulties in providing good healthcare delivery system in India. So the first case of pandemic came in India around January, and by March we were all panicked about how to deliver the healthcare process in India. We had around 43 million infections and the second most affected country in the world. So health management in India becomes a central and a state subject also. So in the state, it is managed partly by the local government and the health administration. So India they had to plan to face this pandemic, and it had already had worked with two models. That is, one is the public-private partnership model, and another thing is the handling the Nipah virus, which had happened in Kerala government. Kerala state, and the government had handled this infection in an with the isolation processes and this contact tracing processes. So with this background, we had lot of challenges in India. So challenges were like acute shortage of beds and non-availability of infrastructure, lack of hospital preparedness to handle the new healthcare delivery system during pandemic, lack of contingency plan. We don't have any plans like how to handle epidemics and pandemics. And except for accredited hospitals, we don't have much standards or assessment standards which are followed except in accreditation hospitals. Other than that, we have shortage of this healthcare staffs, and out-of-pocket payments are very high in India. So what was the strategy we took up is that the government under the Ministry of Health and Family Welfare and the ICMR, that is the Indian Council of Medical Research, together came out and started planning for the strategies and how to plan to tackle this and control the spread of infection in the month of March. So ICMR, the COVID-19 testing in India guidelines was initially brought out, and there we first thing what India did was to set up labs. So we had initially few virology labs approved by ICMR, and these were labs with set standards and assessed by ICMR, then only approval was given. So these labs were set up in phase 1 only, but very few labs, but this did not have the capacity to test such a big population. Next, emergency task force was created where the state and the central worked together along with the local administration to which had a team like the district health officer, the police, the infection and the surveillance officers, the district collectors. So all of this in each district work together to form a team and maintain the delivery process in the state. Next, what really changed is an PPH model. That is when the administration, local administration and the government, because of the lack of beds and the resources available with the country, they said this PPH model has to be followed. So all the hospitals, teaching hospitals, semi-government hospitals and corporate hospitals joined hands with the government, and we set up the PPH model where we could allot the beds easily to the general population. How this was done? We could do this only with the technology. We had a robust technology, that is the data management system. Every hospital who was supposed to provide these beds for the COVID population was supposed to register under this portal, and every hospital daily, on day-to-day basis, real-time basis, we used to update the statistics like the COVID positive patient, the discharges, the death rate, the ICU patients, the ventilator patients. All this on day-to-day basis was updated. Each hospital data was checked by the local administration. Local administration, further it was shared by all the stakeholders in the country. And because this analysis, data analysis, made it easy within the country to go into more decision making and guidelines. So ICMR started issuing all guidelines day to day, and till to 2022, we have guidelines and still coming through ICMR to handle the pandemic status. So and online training for all the health workers, we had online trainings which got clear instruction from the central and the state government on how to handle the pandemic patients. So coming to the hospital, as in hospital, how did we change the healthcare process? In each hospital, we had a team, that is a COVID task team. And this included an administrators, clinical heads and treating team, lab director, ICO, that is an infection control officer, nursing head, housekeeping and engineering department. So with all this, we formed a team in each hospital. And we also had the COVID committee, and certain big hospitals had multiple committees like administrative committees, a medico-social department, their own committee, logistic committee, financial committee. But a medium-sized hospital had a COVID committee where we implemented all the guidelines which the ICMR was sending on day-to-day basis, and what the local government and the district administration health management was sending us. Then we started training all our healthcare workers to the new guidelines, and both healthcare and non-healthcare workers, both were trained with all the guidelines, and we started implementing them. Then inside the hospital, we strengthened the infection control practices, the cleaning and disinfection methods, the use of PPEs and how to use them, donning, doffing, everything was trained to the staff. We had a lot of infrastructure changes to be done to provide this healthcare. Like we had to change the hospital areas into COVID wards, COVID ICUs, HDUs. Even the OT was changed from positive pressure to negative pressure. COVID ICUs, we needed a lot of this dialysis backup, the ventilation backup, oxygen backup. So many of the infrastructure changes we had to do, and we had to spend a lot on the resources also. So and thus the trainings were given to all the staffs accordingly. When coming to the patient flow within the hospital, what we can say is as the patient came to the hospital, we had the first process of screening and triaging practices. And it was made mandatory to all the hospitals, and we had done this for all our emergency department patients and the OPD patient. We set up a liver clinic outside the hospital, and every patient entering the hospital had to go through this and to divide themselves as COVID suspects or non-COVID suspects. And based on that, we had to admit them or in the suspect area, or if they are found to be positive in the COVID areas. Then we had very strict visitor policy where we didn't, we had to maintain total no for the visitors. And then OPD was not functional for a year. Elective surgeries were not done for a year or so. The ICMR approved more labs, and our hospital, we also had our lab approved, and so that we had the capacity building there, and we improved on the testing capacity. Then we also had telemedicine consultations, which was very much important during the COVID timing. And we worked a lot towards prevention of complications, that is reducing of VAP, then hospital-acquired infection, mucormycosis, and regular audits were done for all the COVID patients, and we had to report all the death audits to the government administration, and if there is any variations, we had to personally go there and answer them. So these were some of the steps we have taken towards to bring about changes in healthcare processes during the pandemic.
Thank you, Dr. Marla. So given the limited time, I would like to switch over to Dr. Selvaggi and see, Dr. Selvaggi, what is your take on this?
Yes, we saw changes here also very similar to what Dr. Marla was describing. Perhaps the most difficult changes to the healthcare delivery process started with the pandemic beginning and changing what we typically did from acute care to preventative care to routine surgeries, just the usual business, to really chasing everyone home, leaving them at home and treating them only for acute processes. It actually idled our hospitals initially when there was no major epidemic in the region. And then, of course, when the epidemic did come, we were overwhelmed with patients in the acute care setting. Not only there were patients sick, all of them at the same time, but our staff members were sick, so we had shortages of staff and essential workers. And that perhaps was one of our greatest challenges. Now there have been several epidemics, and we've been through this several times. Things are returning to normal, more normal, at least for us. But that's perhaps the biggest change in our healthcare delivery process. So it's what Dr. Marla described, just the process of trying to develop science, some techniques for even identifying the disease process, followed by effective treatment, and just trying to keep people alive on the ventilators and supporting them with fluids and basic services. So I would say that the healthcare delivery process has changed quite a bit, particularly when it comes to trying to prevent contagious disease from being passed from person to person. That's perhaps the most persistent result.
Thank you, Dr. Selvaggi, for that quick and beautiful answer. So my next question is to Dr. Anu and Felicia. And the question is, I'll start with Dr. Anu. Is there a need to expand the outreach of healthcare services to counter any future epidemic or pandemic? How can we achieve that? So we'll start with Dr. Anu and hear from Felicia.
So good evening, good morning to everyone here. And again, I bring greetings from India. And at the outset, I would like to thank the University of Central Florida and AJ Medical College for creating this platform to address all these challenges posed by COVID. So to answer your question, we just needed to expand the outreach healthcare services, especially in our country, India, with 1.4 billion population. it took us some time to understand the challenges, as Dr. Amitha has already informed you. And so all the processes had to be changed dynamically in real time as we started getting in information. And in terms of outreach, Government of India has nearly 28 different states and 9 union territories. And overall, we did a good job in containing the whole crisis. And the healthcare system was already burdened. And with the pandemic, you had to take care of the outreach services. All the essential services had to be happening in the rural and semi-urban areas. So we had to reorganize the whole service delivery now. So the public and private partnership had to be done to create separate COVID facilities, and the state government specifically partnered with government empaneled private hospitals. That was a big move, and this was the first time this has been done to help out in the shortage of beds. But going forward in the future, I think there is a tremendous need and opportunity to strengthen and synergize this public and private partnership model so that we increase our own capacities to take care of future epidemics. And in Tamil Nadu specifically, that is the southernmost part of India, we were taking care of all the chronically ill patients, like those patients undergoing dialysis, chemotherapy, and patients who were in need of blood transfusions. So the government created a list of all these patients. First, they got that list from every hospital, private and public. And during the lockdown, they ensured that these people were transported to the private and public hospitals. That was a very good move from the government. And where they ensured that all these essential services were still happening in all the hospitals. And again, our hospital is called the Sree Renga Hospital, which is in Chengalpet, Tamil Nadu. And we cater to semi-rural patients, semi-urban patients also here. And we were taking care of all these emergency patients 24/7 in our hospital. And all the obstetric patients, they needed care and delivery during the COVID pandemic. So again, the list of all the patients who had to deliver and all the emergency obstetric high-risk patients, the list was got, and they were able to connect to the hospitals directly. And we need to create more number of mobile units to reach the village people to take care of all these antenatal patients in the future. That should be the mode of improving the public outreach. And again, when we talk about outreach services, we need more amount of screening and awareness camps in the various communities to specifically take care of non-communicable diseases like diabetes, hypertension, because we were able to see the amount of deaths due to these comorbidities during the pandemic. So we need to ramp up all these screening. And to create it, you need to have a hub and spoke model where the complicated cases will be handled by the hospitals. The other awareness and screening facilities can be done in the villages itself. So our hospital has been conducting various outreach programs in the villages surrounding our hospital. Nearly 100 villages, we were able to serve these villages last 20 years. We have been doing free camps on diabetes and hypertension. And again, we have been doing eye screening camps. So more than 80,000 people have been screened for all these non-communicable diseases. And we do cancer screening camps for women like pap smear, mammography, because all these have to be done in these outreach areas. And these mammography and others, we were able to do with a partnership with a NGO organization who was able to have a special vehicle fitted with mammography and pap smear in the vehicle, and we were able to do it in the villages itself. So these outreach programs help us to identify people who have to be brought back to the hospital. In future, going forward, maybe we might, the telehealth services in these villages will help the patients in need so that you can do the counseling and minimal treating and then refer patients to the hospitals if required. In Tamil Nadu state alone, that is one of the states in India, we have nearly 1,384 rural primary health centers and 460 urban PHCs. So they are slowly now being transformed to health and wellness center by the government. And if these happen, this in the non-communicable disease burden will come down in the future. So this is one of the way where we can do the outreach services and help the people. And again, the next important source in any outreach services is the human resource. So getting this human resource is the most toughest part, and you need to reach out to this 1.4 billion population. And the community health workers are the backbone of these whole public healthcare system. So we have nearly 900,000 of them. and they are called the ASHA workers. They are called the accredited social health activists. In Tamil Nadu, they are called the ANMs, the auxiliary nurse midwife, or the VHN, the village health nurses. So these nurses are the interface between the community and the public healthcare system. So they help in creating the confidence in the local community, where we saw this happening in when we had a huge COVID pandemic in the Dharavi slum area in Mumbai. So the local community workers were able to create the confidence, help the health staff in the testing and in helping out in the vaccination also. So in spite of all the challenges because of the huge population which we have, we were able to nearly give 92% eligible population the first dose of vaccine in Tamil Nadu state even. So we were able to take care of antenatal patients, the drugs which have to be given door to door for chronic patients like tuberculosis, HIV, all these are done by these community health workers. So in future, the training of these workers have to be strengthened to help in these outreach programs, and even again, they have to be well paid, and maybe you have to keep them motivated, give them some insurance benefits, and this will strengthen the all the outreach services. So we have had great learnings from COVID across the country, in every country for that matter, across the world. And healthcare systems have faced the worst challenges now in the face of this crisis. So moving forward, the way is to have a promotive, preventive, and primary healthcare aspects of every nation. It has to be strengthened so that we don't have huge comorbidities happening for any pandemic. Again, you have to strengthen the public health systems to make it more accountable across the country. And all these smaller private organizations, which are the backbone of the first step which any patient comes into in rural areas. So they have to be sustained. You have to incentivize these smaller hospitals so that they are able to sustain and run these small private hospitals. And for this, the public-private partnership will help to effectively utilize these resources. And you need to have a good trained healthcare workforce. So these are the things which will help the outreach programs in the future. And so as a country, India has coped and adopted to all these challenges. And it has been a great privilege for us to be part of this great country in the efforts to contain this pandemic. Thank you, Dr. Mr. Varadraj.
Thank you, Dr. Anu. Felicia, I will turn over to you for your take on this particular question.
Okay. During the pandemic, we found, we saw a lot of challenges, especially with the geriatric population, just trying to provide a safe outcome for them. Decreasing the risk of exposure, as a staff member, going home, being out in the public, returning back to work, just trying to provide the best safe outcome for them. But continuous disease surveillance and reporting provided essential collaboration between healthcare system and the public health agencies. The public health officials, offer guidance for treatment options for the geriatrics, the staff members that was, exposed or affected by the individual. We had guidance from CDC, other regulatory agencies to help us, to provide the best treatment for the resident. Also achieving and practicing meeting the patients where they need in the clinical aspects. We had different doctors doing telehealth visits to help just control just the basic hypertension, COPD, the basic needs of the patient, just to decrease the exposure and risk of them going to the hospital during that time.
Thank you, Felicia. We are quickly running out of time here, so I would request the panelists to be a little bit brief and quick if possible. So next question is for Dr. Selvaggi, and the question is, how has the pandemic improved the need for telehealth and healthcare information systems? I think the panelists spoke about telehealth a little bit, but Dr. Selvaggi, your take on this.
I think that the need for telehealth has dramatically increased. The fear of exposure to infectious disease has driven everyone to allow that to take place. early on, I think everyone recognized the importance of reducing everyone's exposure to the virus. And so government officials, insurance companies, providers, healthcare workers, patients, everyone recognized how critical it was for us to not mix together, stay 6 feet apart at least, if not stay home. And the only way we could deliver healthcare is for us to be able to reach out and see these people. And so I think critical telehealth became critical for that reason. And it still is. I mean, it was pretty much forced upon most of us. Some people were already doing small amounts of telehealth, but it became the mainstay of what we were doing. And it was essential for curtailing the epidemic. So I think that it was a lifesaver. There's still a lot of questions I have about how it can best be used that need to be answered. What are the circumstances that you can use it effectively with, and when do you actually have to examine your patient? And those are clinical judgments, of course, but there should be some science developed to help us and guide us along those lines.
Thank you, Dr. Selvaggi. So I believe that more and more patients are now accepting telehealth, willing to be there, I think the resistance against telehealth is slowly but surely going away, especially in the rural areas, because this has been one of my areas of research in the past, acceptance of telehealth in rural areas. Okay, so Dr. Marla, your a quick take on this, just a couple of minutes from your end. You're on mute, ma'am.
Yeah, in India also, we during the pandemic, we really felt the need of the telemedicine, and the guidelines were made legal in India only in 2020. And because of that, many registered medical practitioners were able to practice better. The long distance need to be covered by the patients also reduced, and traveling time reduced, cost reduced for the patients, and there was faster access and easy access to the patients. But it was also in India, we had in two forms, that is government also in the hub and spoke model, they have utilized this telemedicine, especially for non-communicable diseases very well. And in private organization also we are using telemedicine, but the limitation I feel we have still is that the integration with the hospital information system, where the electronic health record does not capture the details of the patient. So this is a bit limitation in India as of now. Otherwise, yeah, telemedicine is useful for pandemic.
Thank you, Dr. Marla. A quick point that I would like to make for our American audience here is that the term central government in India is the same as federal government here in the United States. And when someone uses the term district in India, the term district is equivalent to the term county here in the United States. So just wanted to make it clear to our American audience here. So next, I would like to move on to our, final question. Do you perceive any changes in lifestyle or hygiene among the general population due to the pandemic? And this is a question for Felicia, and we would like to get a response from Dr. Anu on this. So Felicia, the floor is yours.
Okay. The pandemic has induced changes in all aspects of life and living habits of the people, such as self-isolation, social distancing, to reduce the person-to-person contact for risk of exposure. There's been an increase of dietary supplements. We saw multiple people's, increase in vitamin C, the vitamin D, the elderberry. When it comes to hygiene habits, more people were washing their hands frequently. Compared to the period before the pandemic, there was increased use of disinfectant supplies, more people, deep cleaning, changing or removing clothing prior to re-entering your home quickly became the new norm. Me, myself, would also disrobe before I even enter my house, straight to the shower. A lot of nurses, was doing what they had to do to just protect their family and changing the habits of, just coming in and or going to the store right after work.
Dr. Anu, what do you think from your end? You are operating in a rural area, so that might be a challenge a little bit, but now things may have changed because of the pandemic.
Yes, so pandemic has definitely had a huge toll on the general population, specifically the rural areas, because lives and livelihood have been lost globally everywhere. And again, lockdowns and disruption have damaged economy everywhere. We had seen the huge migration of the workers, which was not seen in any other country. It was a huge migration from various places in the states across India. So these were some of the things which poses challenges. And generally, as Ms. Felicia has told us, adopting right lifestyle and maintaining hygiene has been the norm now. So because this is the key to good health outcomes, and everyone, the awareness has increased definitely. And during pandemic, because we specifically had so many messages on YouTube, WhatsApp, and there has been a huge sharing of information across all the social media. And again, when the government had restricted the movement of people, everyone started putting out their mats and started doing yoga and started learning exercises and other things. Again, the celebrities, film personalities, everyone started put up their own videos, and that has been a huge motivation across the countries. But when you go through these lifestyle, the change in lifestyle, it has affected every person's lifestyle now. So many of these school students were affected very badly. There has been a huge dropouts of school children in every state now. And so every state government is trying to pick up these school dropouts, because the quality of education, many people, they were not able to take up the online classes in very remote areas. And again, college students had a different set of problems because their future was very uncertain during the pandemic. And this created more amount of stress among the general population. Again, there was so much of layoffs in the working population. So the mental health was definitely affected. And so we saw a huge amount of stress-related issues in IT population. And again, the elderly, they all felt very much isolated, because many of their relatives were not able to visit them. And so they had to adapt to various Zoom calls and other things, and this had a significant impact on their health. So these are some specific issues which we had, and so there was a huge amount of change in lifestyle. But hygiene-wise, there's been improved hand washing and repeated cleaning of every facility, be it the hospital or in the house, and improvement in the waste management techniques, and again, use of mask across every state. Now there is again talk about the fourth wave coming in. So in Tamil Nadu, again, the mask has been made mandatory now in the state. So that's the way it has been going on. So social distancing and other things are, the awareness has created all this. And so the pandemic has touched every life across the world, and we need to be united. Like this has been a good platform to exchange all our ideas and suggestions and what we have worked in each of our own place. So we have to make sure that whatever gains we have done because of this improvement in hygiene, we need to sustain it even after this pandemic gets over. Thank you so much.
Oh, wonderful. We have lots of time for the audience to ask questions to our panelists. I think I see one question here. What long-lasting changes from the pandemic health practices do you see remaining with the hospital systems? I think this would be a question for Dr. Marla and Dr. Selvaggi. Dr. Selvaggi, I'll start with you first and then move on to Dr. Marla.
I think that we're going to be much more careful about infectious disease. I hope that is there in 10 years if we don't have another new disease or epidemic occur. I think the policies for the staff to follow concerning masks, concerning washing hands, and other measures used to prevent disease will stay in place. With this new epidemic, it raises the question of what else can and will occur in the future. And certainly what we've had with 1% mortality rates of COVID-19 was devastating worldwide. But something with like an Ebola 50% infectious disease rate with the contagious capacity of COVID-19 would be particularly disastrous for the entire world. I hope that we are able to maintain constant surveillance and reporting of new diseases so that these can be identified and interventions put into place as early as possible, including research. I hope the hospitals worldwide, particularly in this country and India, everyone involved will be participating in that process.
Dr. Marla, your take on that question, ma'am? You're on mute.
Yeah, long-lasting changes for the hospital would be like, we have really learned a lot of lessons from this pandemic, and the hospital has now learned how to prepare itself. So hospital preparedness is one thing which is going to stay for a longer time. So we have though we had an infection control department, practices department, but when we have pandemics like this, we really didn't have a thought of how exactly we will handle this. So we have now so many policies and protocols in place, and the training schedules and modules in place, and this has to continue for a longer time and forever, because we don't know, as Dr. Rick said, anytime we might have such situations in future. So strengthening the infection control practices, increasing the awareness among healthcare workers is one more thing which we all need to practice in day to day, and this is also going to stay for a longer time.
Thank you, Dr. Here is a question coming from an audience member. Can you please discuss your experience with international cooperation to combat the pandemic? And I would actually go to Dr. Anu for this and see what you're feeling about the need for international cooperation. Like, for example, I was in Taiwan, August 2019, and I saw people wearing masks, walking around, and there was a disease control unit. I was thinking, like, what is going on here? And I couldn't think about, people wearing masks and all that. And then, in 2020, a few months later, it became a reality. So, so what is your opinion on, international cooperation, people traveling between countries, and, is there a need for more international cooperation to combat this type of thing?
Yes, definitely, Dr. Varadraj. We definitely need this international cooperation among countries, because there is a Sanskrit word. Sanskrit is the oldest language in the world. So it's called the Vasudhaiva Kudumbakam. So every person, so one country, one world. So every person is important, and you need to have cooperation among societies, among cultures, because when we saw this pandemic, it was not restricted to one area. It's slowly started spreading, and across the world we had a huge crisis. So to overcome all these crises, we need to learn from each other. So what worked in that country, what worked in others. So we need to have a research protocol which we can share with each other. Again, when we saw during the pandemic, India, in spite of all the difficulties, was able to send out drugs from this country, medicines and whatever was needed essentially to the neighboring countries. Again, when the vaccine was found, they started sending out vaccines to other countries. because it is not enough to safeguard your own country. You need to help each other so that this pandemic, we are able to overcome this pandemic. Again, during lockdowns, we saw people had to be brought back from other countries. So this was done only with cooperation between the countries. So in this way, to overcome these type of pandemics in the future, we need to work internationally. We have various international platforms like the ISQA, the International Society for Quality and Healthcare, the WHO, and all these have to come together, and so that we are able to overcome these crises. Thank you.
So there's another question coming up from, there are a lot of questions coming up from the audience, which is good, which is very unusual, but it's good. So this question is for Felicia. I would present this question to you. Do you think the life is getting normal in Texas and India? Do you think that the pandemic is pretty much gone? Felicia, what is your take on this one?
Somewhat is returning back to norm, but it's also a new norm. It's continuing to, the hygiene, being cautious of, the environment, just taking safety when you're out and in public. Even just going to work, the challenges of staffing, having, enough staff to provide care for the residents or in any healthcare. It's just been a shortage of help. So it's kind of hard to say what is coming back to be norm in Texas. It's the new norm for us.
Okay, this one is for Dr. Selvaggi. Dr. Selvaggi, there's a question on herd immunity, and you are a highly experienced physician, dealt with a lot of patients over the years. Do you feel that there's going to be herd immunity, or are we going to have these cycles coming up every other year, where we have to go in lockdown and then we come out, and when is this whole thing ending from your perception?
From my clinical perception, I think that we're approaching herd immunity, at least in our area. Our vaccination rates aren't particularly that high, but our infectious rates have been relatively high. So between people being infected, people being vaccinated, there's been multiple exposures to the virus. And I think the majority of people now have some immunity, and I think we're seeing some of that herd effect. I think things are improving for us, and I hope it, even though the virus is changing, I'm hoping that the previous exposure to the virus by most people will provide us protection and prevent any more of this severe epidemics that we have seen to date.
Okay, thank you, Dr. Selvaggi. This would be a question for Dr. Marla. Do you see any changes or that are needed for mental health? For people dealing with mental health, do you see that as one of the challenges, with the pandemic? Like, for example, if a person is suffering from dementia, severe Alzheimer's, is just walking around, doesn't know how to get back home and is actually spreading the disease. Do you see that kind of situation becoming a threat, or what is your take on that? You're on mute, ma'am.
Yeah, there's a definitely impact on mental health changes, especially during the pandemic lockdowns. In India, mental health changes first we saw in healthcare workers also due to the acute shortage of staff in hospitals. So all the healthcare workers had to do a lot of extra shifts and all that. So that had a lot of impact on their mental health. So we were giving them psychological and social support so that they cope up with their work and break through. And we also saw, because in India we have the social family system and social system is very strong. So during lockdown, we found a lot of elders locked in their homes where there was no much visitors. So we have observed that there is, even in that age group also, depression, dementia, all these changes were showing. And we, in fact, in our hospital, we had started the home health program so as to handhold these people and sent all the medical social workers so that they can work with them and reduce their and give them medical treatment as and when required. We also saw a lot of violence in with the healthcare workers in hospitals. So this is we during the public was in that sort of depression mode and all that during this pandemic, and this affected they showed it on the healthcare workers whenever they used to visit the hospitals. So in even in school children, we see that they are slowly changing their this. So behavioral changes are there. So overall, we felt the mental changes are having a very much impact during the pandemic.
So Felicia, I want your response on this. What do you think about the fatigue factor for healthcare workers? You being a nurse, and this pandemic created the fatigue, the extra pressure on the nurses that they couldn't deal with.
So my opinion, it was very challenging. The stress of providing the care for the residents, the stress of getting supplies that we needed to provide the care, and just seeing our residents being isolated away from family took a toll on the residents. Also, the staff being isolated just from the staff members that they're used to working with. We also had to continue to stay social distance with between us during breaks, while we're on the floor, trying not to be too close to each other during that time frame. But it has, with the numbers going down, it has gotten a lot better, been able to be more social, the family members are back in the facility, the residents are, more happier, less, behavioral, being able to just to see their family and know that they weren't forgotten about.
Yeah, thank you, Felicia. So the next question, I think we are getting to the end of this discussion here. I want to make sure we respect the time. So this question is for Dr. Selvaggi, I believe. So here, do you believe, okay, here's this other question. Are we moving into a cyclic coronavirus outbreaks by season? Will there be a plague season when we have to physically distance more than other times? Like we have this flu season in America, are we going to see that a COVID-19 season every year or every other year, where CVS Pharmacy would be promoting COVID-19 vaccines every year or something like that?
I think it's a little bit early to say. The science is evolving, our experiences are evolving, but it does look like we're going to probably have periodic vaccinations for COVID. And I do think that there will be times in which COVID will be more common. And it's been somewhat unpredictable up to this point in time. So I think it will probably remain in that pattern, somewhat unpredictable. But I think time will tell us. But I think it's, instead of looking at mortality rates from flu and pneumonia, we're going to have COVID, flu, and pneumonia listed. It's going to become part of what we look at and keep track of.
Okay, I think one last question, and this would be for Dr. Anu. Dr. Anu, do you see things getting normal in India right now? You said India is getting ready for the fourth wave, but do you see things getting normal, and you think that this normalcy would continue? Hard to predict, but you could be right or you could be wrong, but that's a question from the audience.
Yes, anyway, we shall be more optimistic about this. So, because all of us have gone through these 3 waves, and we have understood how it is evolving, and so many of them have been vaccinated now, And so even if most of the hospitals are ready to face the next wave also. So most probably we might, it will come down in the near future. It will be like a flu season on and off, and all of us will be able to face it and go through our life. Because we have been having 2 years of difficult times. So we shall hope for the best. Thank you.
Okay, so Laila, the floor is yours. I think I'm done with my question and questioning the panelists. So the floor is yours for winding up this discussion. Thank you.
Thank you, Dr. Gurupur, for organizing and leading this educational global discussion with such a wonderful, knowledgeable panel. Thank you, Felicia, Dr. Selvaggi, Dr. Marla, and Dr. Anu. I appreciate you taking your time early this morning in Texas and this evening in India to speak with us about your experience in response to COVID-19. And thank you again to the University of Texas South Asia Institute for co-sponsoring today's event with the India Center. I want to thank the audience for joining us today and participating. And we hope to see you again at future India Center events, either in person or virtually. Thank you again so much for joining us.